LRTI is actually an acronym for lower respiratory tract infection, and which could be mostly thought of as pneumonia, but does include some other disease states like acute bronchitis. The diagnostic tests are important in this area because of the burden of LRTI and the difficulty in discerning whether a LRTI is due to an initial viral cause or a bacterial cause. Traditional historic tools such as the chest X-ray or complete blood count really don't give a full picture to the clinician about guidance on whether something is viral or bacterial, or who's going to benefit specifically from antimicrobial therapy. The correct therapy is critical because no medication is innocuous. Every medication has side effects. And when we indiscriminately or inaccurately or prematurely treat someone with broad-spectrum antimicrobial agents, we all, or most of us, are starting to realize what a risk that entails in terms of very common side effect, obviously, gastrointestinal, nausea, vomit, and diarrhea. But allergic reactions also occur quite often in my practice, allergic reactions to antibiotics, and possible effects on the liver, kidney, other organ systems. So you can't really prescribe an antibiotic without having a good reason to do it. And we know from the societal level, of course, that total antimicrobial exposure multiplied over the thousands or millions of people who are getting a given antibiotic is really where the strain occurs worldwide. In the context and the background of all this is, it depends on the day, the season, but I would say about 80% or 90% of what I see clinically in my practice is viral. TRAP is an acronym that stands for Targeted Reduction of Antibiotics using procalcitonin. And the goal of the TRAP trial was to determine if a low procalcitonin could be reliably used in patients presenting with LRTI to successfully avoid antibiotic use. The TRAP trial had 3 endpoints at time endpoints, 5, 11, and 28 days. And the authors looked at 3 outcome measures. Clinical improvement, which is, the basics. Did the cough get better? Did fever go away? Did the patient need to come back and get hospitalized? And then 2 more in-depth analyses, DOR and RADAR, which are tools now being used in infectious disease antimicrobial research to look at the utilization of antibiotics, the antibiotic side effects, and if antibiotic side effects occur, what the severity of those antibiotics were. And so what this study does is sort of elevate this perspective about the whole patient, the whole picture, not just whether their cough went away, but whether they had diarrhea 2 weeks later that resulted in C. difficile, or whether they had some other side effect that wouldn't have normally been noted in most trial designs. The trial at 5 days did not really show the kind of improvement in patients based uniquely upon the clinical outcomes at 5 days. And there's some fairly good explanations for this. At 5 days, when a patient's on azithromycin, even if they have a viral infection, there are some pretty potent anti-inflammatory properties of that antibiotic that work non-specifically, and therefore the patients might be feeling a little bit better on day 4 or 5 on their Z-Pak, even if they have flu. That's kind of an accepted known phenomenon, and that's probably why a lot of our patients historically have said, I feel better when I'm on, azithromycin no matter what it is. So the important things were the later time points, the 11 and 28 days. So when you take people to what would be the natural end or course of their illness, it turns out that giving a patient placebo, ultimately, clinically, they did just as well. And then in terms of these composite outcomes, the DOR and the RADAR, when we look at their antibiotic exposure, their diarrhea, their nausea, their rashes, they fared better. And so the TRAP trial was successful in that regard by actually looking at the appropriate end outcome. And in my opinion, in this case, it would have been 1 month, right? When most people are through their illnesses. And then looking at it in a really comprehensive fashion, where all the possible side effects are being looked at, not just whether they had a cough. Now, PCT isn't the be-all, end-all. It doesn't tell you what specific bacteria or virus that patient has. It just tells you that the patient is having what we call the host response to serious bacterial infection, and it's a significant flag to clinicians that action needs to be taken. So that's probably its unique feature as a biomarker, or its special quality. I would have to say that the greatest benefit for me personally in my practice as an emergency physician has been the use of PCT in guiding lower respiratory tract infections with that antibiotic reduction concept in hospital medicine, to get patients down, to taper their antibiotic therapy, the number of antibiotics they're on, their days, and to get them off as soon as possible, as soon as safely possible. When a patient comes in, for instance, day 2 or 3, positive viral test or positive RSV test and a negative procalcitonin, and this is what the TRAP trial that we're discussing applies to, and that's patients with lower respiratory tract infections who don't have significant issues on their chest x-ray, who won't need admission, and who we so frequently prescribe antibiotics to unnecessarily. The lady who's got 2 days of cough, no fever, no shortness of breath, nothing on chest x-ray, insisting on antibiotics. We have this viral test which shows you have rhinovirus. And what you really need is some good control of that cough, so you get a good night's sleep, your immune system helps recover, and then don't just say, no antibiotics, go home, go to bed. I actually put out things that are supportive care measures that will make me feel better. We are right in the situation we've been talking about. This is somebody who does not need antibiotics. This is true stewardship in action, really using antibiotics when they're necessary, not withholding them when they're truly necessary, but not starting them in the first place if they don't need to be there.